Welcome to Premier Pain Talk, a podcast dedicated to expanding awareness about treatment options for people in pain. Each week, host Dr. Michael Danko from Premier Pain Treatment Institute in Cincinnati, Ohio, discusses cutting-edge treatments for pain management that are improving the quality of life for those suffering with chronic pain. Tune in now to learn more about how to relieve pain and restore your quality of life.
Hello and welcome to another episode of Premier Pain Talk. This is Dr. Michael Danko, this is going to be a little bit shorter episode probably today, but I wanted to briefly address an article that came to my attention related to a study recently done, a systemic review on Tramadol, which is a mild opioid based medication that's used for chronic pain. I haven't, in full disclosure, I haven't had the time to, I haven't had access to the actual study, and I haven't had a chance to, read that in detail. But I did read a review article on it that was posted on CNN, and I think that studies like these are pretty tricky, and I think when you try to assess whether how the impact is on clinical practice, and I just worry about unintended consequences with articles like these, because you have an article that comes out and says essentially common opioid is not that effective for easing chronic pain, study finds, and then it kind of dives into Tramadol and its limited benefits and how the risks may outweigh it, and that maybe it shouldn't be used. And the reality is a lot more complex than that. So I want to kind of take a few minutes, go through the CNN article and point out some of the highlights from that article at least, and then talk a little bit, kind of take some breaks and talk about how this actually plays out in reality. Because the practice of medicine is complex. The pain management is very complex, and one solution does not work for everybody. In fact, there's oftentimes the same problem has a lot of different solutions, and sometimes almost all of them don't work or none of them work. And then so you have to be flexible. Flexibility is the key to pain management. And when it comes to studies like these, and I think potentially have a risk of negatively skewing one of the tools that we have at our disposal, I think that just further limits the flexibility that patients have, because not every patient responds to every treatment, and not every patient's a good candidate for every treatment. And I think that's where medicine like Tramadol often can be utilized effectively, because there are certain scenarios where a lot of other options are off the table, and then that's when we will potentially consider a medicine like that. So I'm going to kind of start piecemeal through it. Looking at the beginning, they're talking about how there's, something called a low certainty evidence, and the Tramadol may reduce the intensity of chronic pain below a certain level that they call the minimum important difference threshold. In fairness, this is the first time in my life I've heard the term minimal importance difference threshold. And it says that basically, that doesn't. The Tramadol doesn't reduce the overall pain scale, pain number over a long period of time, and I think that's fair. But a lot of medicines out there don't do that, and Tramadol is what we would consider a breakthrough medication. So Tramadol is not a medicine that has to be taken every day on a set schedule to have a therapeutic effect. It's not a blood pressure medication. It's not a long-acting insulin for diabetes. It's not a cholesterol medication. These medicines, it's much harder to judge. So, if a patient has a pain level of a 7 and they are struggling to do household chores or things around the house, let's just say doing a load of laundry, they take their Tramadol medication and their pain level stays at a 7 while they're doing those activities, but they're able to complete those activities and they're able to function better with an equivalent pain score, because without that, the pain score would spike and would go from a baseline of 7 to a baseline of 9. And so I don't think it's fair to say a medicine is not meeting some kind of effectiveness threshold if it maintains a pain score that allows the patient to function and do certain activities. So that's just an example of how medications that are intended to be more as needed can help people achieve tasks, but they may not levels, because that's really not what they're intended to do. They're intended to help with the breakthrough episode of pain, and then kind of patients will rely on other things that try to help with their overall pain level. And so when you're looking at some of these kind of studies, I think it's really, really important to kind of understand like whether what they're even looking for, what they're trying to define and assess, actually is what the medication is intended to do. It talks about how although statistical analyses may reveal differences in pain scores between patients, these differences may be so small that they are not perceptible to patients themselves. And I think that's kind of funny. So, if you're prescribing a medication, it could be Tramadol, it could be literally any medication out there. If the patient's not perceiving a benefit and there's not a benefit that's being derived from that medication, that medicine should be stopped. That's not a medicine that should be continued if there's no clinical benefit that's perceptible to patients. So, I think if you're prescribing someone Tramadol, for example, and it's not helping their pain, it's not helping them function, it's not doing something, like I 100% agree that medicine should be stopped and different alternatives should be taken. But that is not unique. If somebody's taking lisinopril for their blood pressure and they still have poorly controlled high blood pressure, maybe we should stop the lisinopril. Maybe that one is having not achieving some kind of minimum important difference or whatever that term was. So I understand that, do you think that everybody that's taking Tramadol out there in the world is taking it for just literally no reason? It's not helping with anything. They're just continuing to gobble it up and take it. Like, of course not. That's not real world. That's not reality. And sorry, this episode is a bit of me in my box, but that just kind of is what it is. There's another. They quoted a physician that talked about how he's not really surprised by the results that essentially these medication, it's not a medicine that he finds to be particularly effective in his practice. And I think that's fair. I mean, we all have different biases on what we think is effective and what isn't effective. Tramadol is a medication that I find to do well for patients who are opiate naive. So patients who you start out on a medicine like ibuprofen or some kind of other anti-inflammatory medication, and the patient has reasons they can't take it. Maybe they're on a blood thinner and they're not allowed to take it because the anti-inflammatory increases their blood pressure risk. Bleeding risk. Maybe there's an issue with their kidneys and they can't take the anti-inflammatories because of their kidney function. Other reasons, and then muscle relaxants are sedating for them. The neuropathic medications are making them too drowsy, giving them blurred vision. And physical therapy didn't work, injections didn't work, surgery didn't work, yoga didn't work, massage didn't work, chiropractor didn't work. And so what do you do if you don't have other options and things to try? So this is a scenario where a medicine like Tramadol could be potentially pretty effective and pretty helpful for that patient. Also, this study compared Tramadol to placebo, but also oftentimes in pain management in the chronic setting, you may be comparing it to a stronger opioid medication. And so you take someone who's not used to taking pain medication, or if you take an elderly patient or someone who's very sensitive to medications, Tramadol may be better tolerated than those medications with less side effects than those medications. So I think that when we're talking comparisons, I think it's so individualized from patient to patient that it's really needs to be factored into our decision making. There's kind of moving through this article a little further. There was a doctor who pointed out that a lot of the trials that were looked at in this review were studies that were 12 weeks or less. So when the study is trying to make determinations about the long-term effectiveness of Tramadol, yet they're looking at research studies that are less than 3 months in duration, like that's kind of really doesn't help for the power of their study, because the data they're looking at isn't even applicable to the question they're trying to, or the answer they're trying to posit, the hypothesis they're trying to prove. Also, I think moving further, I think they started talking about how there was a doctor who's an internist who has a book called "Don't Let Your Doctor Kill You," which actually sounds like an interesting read. I kind of might want to check that one out just for the fun of it. But She mentions how she never prescribes Tramadol, and I realize, I understand, like, probably, I would say an internist who's not a pain management specialist probably shouldn't be prescribing Tramadol. I think that, if the alternatives that they've found that are not non-opioid based options are not working as a internist. So an internist is a internal medicine doctor, or who kind of by definition does like kind of primary care work. That means that they probably don't do any kind of, interventional pain injections. They don't do any surgeries. They don't actually do the physical therapy. They don't actually do, chiropractic adjustments. Like, once whatever medicines they've prescribed that are non-opioids have not worked, I think that internist should be referring to a pain management specialist, because they're kind of starting to get out of their scope of practice. And then it references Dr. Sanjay Gupta, and now he has a book that's called "It Doesn't Have to Hurt: Your Smart Guide to a Pain-Free Life." And so I think that's, I think it's kind of that's a very good thing to strive towards. But ultimately, he also references how about a third of people are restricted in what they can do and how they live, but there are alternatives to medication where you can reduce and even possibly eliminate pain by using our own bodies and minds' capacity to manage it. Options can include meditation and yoga, massage and acupuncture, even emphasizing eating anti-inflammatory foods like whole grains and leafy greens can help mitigate how our bodies react. May even use ice or heat or elevation or rest, quality sleep, and exercise. And then, I think that's fantastic. I mean, realistically, if I'm having an ache and pain, those are all the things I'm going to try. Yesterday, for whatever reason, around lunchtime, my left shoulder started bothering me a little bit. I'm kind of working through it. I slept, tried not to sleep on it last night, and it's still bothering me a little bit this morning. And I feel very confident it's going to go away probably with rest, probably with, maybe a little bit of massage if I needed, or a little bit of elevation, a little bit of ice, and whatever the case, anti-inflammatories. And maybe I'll try to eat less anti-inflammatory foods today. Maybe I'll get a little more whole greens and leafy greens into what I eat today. But that's not like reality for every long-term patient. And so I think that it's really unfair to a lot of patients out there to say, oh yeah, just eat better and exercise and do whatever, and your pain is you too will have a pain-free life, because pain management is a lot more complex. And if you're listening to this and you're a patient and you've tried all those things, you're still hurting. I really don't think it's fair to you that a expert, so to speak, can say, well, you really shouldn't have pain anymore. And it's like, okay, well, what about the fact that I do? And that's where I kind of want to just kind of move away from the CNN article and talk a little bit about where Tramadol fits in my practice and how it impacts, what I do in chronic pain management, and also what other things I do in chronic pain management. So, I think in general, you need to look at the patient's problem and really assess all of the options that they have on the table. So when someone has a condition that can be managed, with non-opioid medications, absolutely, we're going to do that. We're going to really emphasize what anti-inflammatories, if they're safe to do, muscle relaxants, if it's clinically appropriate and people are having spasms, medicines like Lyrica for their diabetic neuropathy. We're absolutely going to try to look at those options. We're absolutely going to see if the patient can respond to physical therapy or a home exercise program that they can do, whether there's a chiropractic adjustments that may be helpful, whether there are solutions like yoga and acupuncture. We're absolutely going to look at those options. And then we're going to look at, is there a surgical option to cure this person? Is there a way to, but they have a herniated disc pinch and nerve, is a hemilemonectomy and a discectomy, could that potentially alleviate and solve this problem once and for all? Is there something like an epidural injection that may be able to relieve the symptoms? If it's arthritis in the spine, can we do a medial branch block and then a radiofrequency ablation and treat the arthritis in the spine that way? If it's chronic pain after surgery, is there a medical device like a spinal cord stimulator or an intrathecal pain pump that may be able to effectively control and manage these symptoms? No, but what do we do for patients when those options aren't working? And I can tell you what happens in the real world. In the real world, if a doctor is not offering other options beyond that, what happens? The patient goes somewhere else. They generally don't just sit at home and say, well, the best that medicine has offered is done for me. Like, I guess my life's over. I'm just going to sit on the couch until I pass away. No, they're going to try to find someone else that can help them. And then, people like like physicians and providers like we have at Premier Pain Treatment Institute, we're going to also consider medication options for these patients. So a generally well-tolerated opioid medication like Tramadol could potentially be the solution that really helps this patient when all those other things have not worked. And ultimately, yes, there's risks. There's risks with every medication out there. There's not a medication out there without any risk. So there are risks for, like mentioned in some of these articles. If someone has a seizure disorder, Tramadol is not an option for them. Someone has, really diminished respiratory function and reasons that a mild opioid may be unsafe from a respiratory standpoint, and Tramadol is not an option for them. But other things like potential for drowsiness and things like that, like those are potential side effects that this medication has. But if the benefit outweighs it, if this is something that actually helps them function and achieve their quality of life they're trying to do, then I think that it shouldn't be just taken off the table because a research study in Denmark said it wasn't it doesn't work for everybody. So I think. Overall, I'll just kind of summarize this by saying I think it's always important to look at that scientific data that comes out. I think it's also important to critically analyze whether that data is applicable and whether it's actually addressing the solutions and issues that are going on in clinical practice. I think this is a bit of an anecdotal, like, okay, yeah, it doesn't work for everybody kind of article study, and it's like, yeah, no duh, like. Not everything works for everybody. So I think if you're currently taking Tramadol and if it's helping you function and it's helping you achieve things you want to do, I think it's avoiding, you don't have any active side effects on a daily basis. I think it's a reasonable medicine to continue. If you are a pain management patient and a lot of other options have been tried and your doctor recommends this for you, I think it's reasonable to try. I think if it helps, keeping in mind if you trial it, we want to make sure the benefits are going to outweigh the risks and that it feels like it's working well for you. If it's not, then we need to find a different solution. And then I think just like everything out there, if you're a patient, you need to be informed. You ask your physician about the potential risks, potential side effects, have an informed discussion, and decide if it is something that you want to trial. But I don't, if you're happened upon CNN like I did and you found that article and you read it and you think that this is completely off the table option for pain management, I'm here to tell you that the real world would say that it's still a reasonable option for a lot of people. So with that, I'm going to wrap. I think that keep in mind that there are chronic pain is complex. It affects nearly 20% of our population. Everybody that has it is actively seeking solutions to try to help, because none of us like to live in pain. And I think that's where be an informed patient, listen, take in information, but try to do your own critical analysis and try to see if you think that the juice is worth the squeeze if a treatment option comes up, and use all the resources available, and don't just rule out an option just because one news article pops up and says it may not be a great option for you, because maybe for you that is the option does work, and for you the benefits do outweigh the risk. And if you're taking it and the benefits are not outweighing the risks, like definitely be an advocate for yourself and talk to your provider about another option that potentially could be more effective. So with that, we'll wrap up today's episode, and best of luck in your fight with chronic pain. Take care.